Good afternoon, and welcome to today's webinar, Managing Anticoagulation and Thrombosis Remotely with COVID-19 Social Distancing, How to Do It in Primary Care. I'm Alan Bell. I'm an Assistant Professor of Family Medicine at the University of Toronto and Vice President of Thrombosis Canada. I'm a primary care physician, and I'm struggling along with the rest of you in terms of managing all of our patients under in this new world, and we certainly hope to assist all of you today in managing issues related to thrombosis care. But at the outset, I'd like to recognize the contribution of all those working in essential services. I'm talking about cleaners, I'm talking about grocery store employees, infrastructure workers, and of course, our colleagues, our healthcare professional colleagues, who are putting themselves in harm's way to help us get through this pandemic. More importantly, perhaps, I would also like to thank all Canadians for physical distancing and the other measures that have flattened the curve and avoided overwhelming the healthcare system. And I think at this time, hopefully, actually allowing us to see some light at the end of this long tunnel. Before we begin, a few bits of housekeeping. The system has been automatically muted for everyone except the speakers. We've got a lot of people on the call today, and not muting the system would create all kinds of problems. We are certainly encouraging you to send us questions. If you have a question, you'll see that there is a chat button at the bottom of your screen. If you hover over it with your mouse, you can click on that chat button and post any questions to it. Due to the large number of participants, though, we'll answer as many as possible at the end of the presentation, but may not get to them all. But we will gather all of the rest, including the ones that are addressed here today, and post them on the Thrombosis Canada website. It'll be on the COVID-19 dedicated area that is fairly easy to find, and we will send you a link at the end of this presentation. Today's program is being recorded for archiving on the Thrombosis Canada website, as well as on our YouTube channel. The content of today's program was developed by today's faculty and our colleagues at Thrombosis Canada based upon their review of the latest evidence on thrombosis and COVID-19. Our presentation and case reviews will be about an hour, after which we'll respond to as many questions as we can and be done by around 3:30 p.m. this afternoon. So thank you all very much for your participation. The next slide, please. Our faculty today are myself, Dr. Lana Castellucci. Lana is an associate scientist in the clinical and epidemiology program at the Ottawa Hospital Research Institute. She is also a staff physician at the Ottawa Hospital and an assistant professor in the Department of Medicine at the University of Ottawa. Jim Douketis is an internal medicine specialist. He is a professor at the Division of Hematology and Thromboembolism in the Department of Medicine. He's the Associate Director of the Clinical Teaching Unit at St. Joseph's Hospital, and he is a staff physician in internal medicine at St. Joseph's Hospital, Hamilton, Ontario, as well as being President of Thrombosis Canada. Next slide, please. These are our disclosures. I'll just allow you to view them for a moment. Next slide, please. I would also like to disclose that this program has received financial support in the form of an unrestricted educational grant from Bear Canada. Next slide, please. Regarding mitigating any potential bias that any of these disclosures may bring forward, I will point out that the agenda and faculty of this program was developed by the Scientific Steering Committee from Thrombosis Canada. I will also go on, rather than reading this thing, to tell you that our sponsor or any other organization outside of Thrombosis Canada has had no input to any portion of this program, nor have they been privy to any of the content of this program prior to today's presentation. Next slide, please. So what are we trying to accomplish today? What are our learning objectives? Well, first of all, we want to cover some of the very basics on COVID-19 and thrombosis. I'm sure you've all heard that this creates a prothrombotic state and raises a lot of important questions. Importantly, from a primary care perspective, we want to help you effectively manage anticoagulant therapy, both direct oral anticoagulants and warfarin and even low molecular weight heparin if you're using that remotely. These drugs are tough enough to manage when you've got the patients in front of you, but we're going to have to help you in this difficult time. And finally, we want you to effectively manage confirmed venous thromboembolism also remotely. We have a lot of trouble with that in primary care, generally speaking, even tougher from a remote perspective. Next slide, please. Our agenda today will, following this brief introduction that I'm providing, Dr. Douketis is going to provide an overview of COVID-19 as a hypercoagulable disease. We're then going to run through a series of 5 case vignettes that are going to be moderated by myself with expert input from Drs. Castellucci and Douketis. We're then going to get a short presentation on outpatient coagulation management from Dr. Castellucci, and then hopefully we'll have time for a question and answer period. Next slide, please. Next slide, please. So, yeah, I think it's a safe statement that COVID-19 has redefined the provision of primary care. But specifically relevant to today's presentation, the diagnosis and management of thrombotic diseases presents its entirely own set of challenges at all times, but even more so now that we have to manage our patients remotely. Thrombosis happens fast. Complications of antithrombotic therapy happen fast. So suspected venous thromboembolism requires urgent and decisive action, and often that is placed squarely in the laps of primary care physicians when our patients show up with thrombotic illnesses. Anticoagulant side effects, specifically the most common bleeding, is very alarming to our patients. We warn them about it when we put them on anticoagulants. When it happens, they're concerned, they're worried, they expect immediate management, and they expect us to know what to do, and they expect us to be able to manage it not only in person, but clearly remotely. And virtual visits make that tough. They preclude any kind of detailed examination that we want to provide to our patients. And we don't really want to send them to the emergency room, and they don't want to go to the emergency room. Everybody is concerned about COVID-19 exposure in hospital settings. INR monitoring also potentially exposes our patients to COVID-19 exposure, so we want to assist you in assisting our patients to have as little exposure as possible and perhaps reduce the frequency of INR monitoring or monitor it appropriately for the times. And finally, COVID-19 infection itself is associated with its own thrombotic and bleeding complications that we as primary care physicians need to be aware of. Now, it would be lovely if in this little presentation, this little introduction, I could assist you in doing all these things. I don't hope to do that. Drs. Douketis and Castellucci are going to provide some excellent insights for you in this, and I think our case studies will help as well. But I'm very comforted to say that Thrombosis Canada has been working, next slide please, has been working for over 2 decades. Can we advance the slide please? To provide, back one, yes, thank you. To provide point of care clinical guidance, and I think that's never been more important than now. And we've been providing this information to you that is ready to access based on our clinical guides and our tools that can guide you through management of complications related to thrombosis as well as antithrombotic management. And we will continue with this mandate to assist healthcare professionals throughout this pandemic with, for example, seminars like this one, as well as continuing to update our website. Next slide, please. Clinical guides. Right now we have 49 clinical guides available on our website that if you haven't seen them, I urge you to take a look at them. You can use them at any time, but the nice thing is that you can use these at a time when you need them most, when the patient is right in front of you with a complicated issue, you don't know an answer to something. Very quick reference tools on 49 topics that are continually updated to provide you the absolute current information on the management of thrombotic conditions, as well as appropriate use of the medications and many other issues. Next slide, please. We also provide you with tools, fabulous tools, tools that will allow you to effectively and optimally manage diseases like deep vein thrombosis when they present to your office. And certainly that is not an unusual presentation in primary care. Next slide, please. We also help you to help your patients by providing 59 patient information sheets that are also available on our website under the Patient and Family tab. These are available to you to download in PDF form and to forward on, get to your patients however you can. Next slide, please. Thrombosis Canada also now has a dedicated section dedicated to the diagnosis and management of issues related to COVID-19. You will find archives of prior presentations as well as this one, and this is also where you will find answers to your questions that have been posed from prior presentations as well as from this one. Next slide, please. So with that, I would like to turn it over to my colleague and president of Thrombosis Canada, Jim Douketis, to talk to us about a little bit on the overview of COVID-19 and hematologic considerations in primary care. Jim?
Thank you very much, Alan. Good morning or good afternoon, everyone. Next slide. As you all know, the knowledge base on COVID-19 is evolving rapidly. Here is some information as regard the etiology, epidemiology, and risk factors for COVID-related adverse outcomes. I think as of today, we have over 51,000 cases of COVID-19 in Canada and approximately 3,000 deaths. Next slide, please. There's a lot of interest in understanding the pathogenesis of this disease. And one thing I think we all need to take away from this session is that COVID-19 is unequivocally a hypercoagulable disease. The mechanism by which it induces hypercoagulability is not clear, but there is evidence based on the pathologic specimen on the right-hand side indicating endothelial invasion, endothelitis, and possible associated vascular injury and thrombosis, in addition to the inflammatory response and, in some cases, cytokine storm that it can initiate. Below, you see some information about the incubation and contagious period, which I'm sure is all familiar to you. Next slide. In terms of diagnosis, clinical and radiologic features and differential diagnosis, a couple of points to highlight. First of all, the typical NP or nasopharyngeal swab has very high specificity. Its sensitivity can be as low as 70 to 80%, but if done earlier in the course of the infection, where there is concentration of the virus in the nasopharynx, sensitivity can be more than 90%. The link there shows exactly how to perform a nasopharyngeal swab to limit the number of false negative tests. I think we're all by now familiar with the clinical features of COVID-19, as well as some of the radiologic features. In the bottom right-hand corner, you see an interstitial disease pattern on a plain chest X-ray, and in the CT scan, a more advanced picture of ground glass appearance that we see in our more critically ill patients. And not to forget that there are other conditions that can mimic, that can overlap with these somewhat germane symptoms of COVID-19, and especially as we will be heading into the fall and influenza season. Next slide. Treatment is an area of intense research. For the time being, as you probably know, the treatment of COVID-19 is supportive care, including oxygen, and if there's suspected bacterial superinfection, antibiotic therapy. The array of treatments that I've listed below, including anti-inflammatory, antiviral, immune modulating treatments, plasma, and in fact, pertinent to this discussion, trials looking at different intensities of anticoagulant therapy are ongoing. But none of these treatments, as of today, have been demonstrated to show efficacy in the prevention, progression, or in terms of important outcomes based on well-designed randomized trials. The website there provides a more comprehensive listing of the trials that are ongoing and some of the drugs that are being investigated. Next slide. As I mentioned, COVID-19 is a hypercoagulable disease, and there is a very high incidence of thrombosis among hospitalized patients, and in particular, critically ill patients that, depending on studies, can vary between 20 and 40%. These patients also have very high, that is greater than 4,000, in some cases greater than 10,000, normal being less than 500 D-dimer levels. But it is unclear whether this is a marker of the underlying pro-inflammatory state, and at this point is not necessarily predictive of thrombosis. One thing that we will be talking about is that patients with COVID-19, when hospitalized, should all be receiving anticoagulant thromboprophylaxis, and in some cases, they should be considered to receive higher dose regimens, especially if they are obese or overweight. One of the areas that I know is important for a primary care physician is the management of patients in long-term care facilities, and we can discuss that. Next slide. Here are some guidelines from international groups as regard diagnosis and prevention and treatment of venous thromboembolism in patients with COVID-19. And there are other societies that likewise are working to update and provide sensible guidance for clinicians regarding thrombosis. Next slide. And in terms of, this is a question that the prophylaxis of thrombosis, this is a question that comes up very frequently. At this point, what appears to be the practice is to administer prophylaxis to all COVID-19 patients who are hospitalized and consider a higher dose regimen in patients who are deemed to have a further increased risk, but not to go to a therapeutic dose regimen for primary prophylaxis. So a lot of interest in this area, and we'll go to the next slide. We can talk about this in the Q&A.
Thank you very much, Jim, for that brief but thorough overview. So let's talk about managing anticoagulation and thrombosis remotely. We're going to use a case-based approach. Can I have the next slide, please? So let's take our first case. This is a 55-year-old female patient who calls about a 3-day history of progressive left leg pain. And on the phone, she describes to you unilateral left lower leg pain, redness and swelling from the knee to the midfoot. And on your questioning, she tells you, yes, indeed, it does pit when you put your thumb on it. She has no systemic symptoms. She has no chest pain. She has no shortness of breath. She has no clear provoking factors, but has been much less active due to self-isolation and admits to spending lots of time in bed. She is not a suspected or confirmed COVID case. She has no history of local trauma. Her past medical history, well, she's obese, she's type 2 diabetic, she's hypertensive. She's never had a thrombotic episode. Her last blood work was done about 9 months ago, and that was within normal limits. And now it's up to you to manage this patient. And the last thing that she wants to do is go anywhere near a hospital. So what do you think? Is it safe to initiate empiric anticoagulant therapy by telehealth? Lana, can I turn this one over to you?
Yes, thank you, Alan. Good afternoon, everybody. It's a pleasure to be part of this webinar. So on this slide, you can see the important points that Alan has highlighted. And On the right-hand side of the screen, you're going to notice what we use to grade somebody's risk of DVT. And this is the Wells criteria for DVT with all of the factors listed there. And based on our patient's description of her symptoms, we've identified that she has pitting edema to the left leg, and we've asked her to measure her leg, and it turns out that she does have a more than 3 centimeter difference in leg circumference around the calf. And so that gives her a score of 2, which would suggest that her risk of DVT is actually high. And so when we're looking at this patient and calculating a risk score to be high, we need to take a multi-pronged approach where we want to initiate anticoagulation while we're simultaneously organizing for investigations of the DVT. Next slide, please. So what we're going to do with this patient is, as I mentioned, we do want to initiate therapy for DVT while we're organizing for testing to be done. And because the direct oral anticoagulants are so simple to administer, the 2 that we would recommend using in this setting are those that are straight to pill without requiring low molecular weight heparin use first. And the 2 options are listed there. So there's apixaban or Eliquis with the dosing regimens there. And the second option is rivaroxaban or Xarelto. And it's important to note that the dosing is different for deep vein thrombosis compared to atrial fibrillation. So just want to highlight that there is a dosing strategy that you need to be aware of. And while we're faxing this prescription to your patient's pharmacy, we do need to organize for imaging and lab investigations to be done. And so you're going to complete a requisition so that your patient can go to the nearest diagnostic imaging facility, and whether that is an outpatient place or your hospital, it does need to be done. And so we would advocate that the imaging be done within the next 24 hours, if at all possible. And we're also going to ask that you do routine blood work on your patient, which would include a CBC so we can evaluate their baseline hemoglobin and platelet count, as well as a creatinine to look at what their renal function is so we can ensure that it's safe to continue the direct oral anticoagulants. And while we're also doing all of this, as Alan mentioned, we do have these great tools and information sheets on the Thrombosis Canada website. And so you can download this information sheet on, you have a DVT, and you can email that to your patient or get it to them somehow so that they know what symptoms to monitor for and when to seek additional medical attention. And the additional medical attention is necessary if your patient endorses symptoms of chest pain or shortness of breath, because that is concerning for pulmonary embolism, and we don't want to miss a pulmonary embolism. And so it's important to instruct your patient to go to hospital in those settings. Next slide, please. So we organized for the patient to have an ultrasound, and these are the findings of the ultrasound. So on the right-hand side here, you can see that the popliteal vein is highlighted, and then on the very right-hand side, when you try to compress the vein, it doesn't compress, indicating that there's a thrombus present in the popliteal vein. And so the popliteal vein is considered part of the proximal venous system, so it is a proximal deep vein thrombosis, and this does require ongoing anticoagulation management. And depending on which direct oral anticoagulant you initially started, you would continue with the regimen as prescribed. So the next thing to figure out is how long are you going to treat your patient for, when do you need to organize for a follow-up visit, and when can you safely organize for an in-person visit. And I think a lot of that is obviously going to depend on the status of COVID and what we're doing with physical distancing and when clinics and other healthcare facilities can open safely. In the meantime, I would suggest that what you do is have your patient continue with their anticoagulant, continue to monitor for improvement of their symptoms. And it's important to know that it's going to be time that also works to improve their symptoms, not just the anticoagulant. And so we're really looking for week-to-week improvements in their symptoms and not necessarily daily improvements. And so I would recommend having a follow-up call with your patient if you can't see them in person, at least a week after you diagnose the blood clot, to ensure that their symptoms are improving and that they're tolerating the anticoagulant well, and that they're not having any adverse side effects from the anticoagulant, such as bruising or bleeding. And so when do you want to do that in-person visit? As I mentioned, it would be important to do it as soon as is safe to do. And the alternative would be if you can set up a video chat or some sort of FaceTime chat, Skype, for example, with your patient. That might be able to at least give you some visual interaction with your patient until you can see them in person. Next slide. So these are other things that you want to consider. So what I didn't mention when you're sending your patient for an ultrasound, this will depend on your facility where you're doing the ultrasound, but many places will do a whole leg ultrasound, which can be helpful in diagnosing a distal DVT or a calf vein DVT, for example. So if you have the option of asking for a whole leg ultrasound, I would advocate for doing that in this time of the COVID pandemic so that you can minimize additional visits to imaging facilities and potentially get a diagnosis with your first ultrasound image. And so if you do diagnose a calf DVT or a distal DVT, in the time of COVID, I would recommend that patients be treated with therapeutic dosing of anticoagulation. And again, this is to mitigate recurrent visits to healthcare facilities unnecessarily. If we were outside of the pandemic setting and we had the option of doing serial ultrasound, that might be a nice approach that we could use. But in this setting, I would consider using therapeutic dosing of anticoagulation, which would be the same as what we saw for the proximal deep vein thrombosis. And the duration of treatment in this setting, I would say, would probably be about 3 months rather than potentially longer, which we might do in a proximal DVT, for example. One of the other things that you may find on your ultrasound is a superficial vein thrombosis, so a greater saphenous vein thrombosis rather than a deep vein thrombosis. And on the right-hand side of your screen, you will see a strategy that we have listed on Thrombosis Canada website for different treatment options that can be utilized. And again, I do think that this is a time where using anticoagulants is very acceptable so that we can minimize patients having to return for repeat imaging. And so you can use one of the strategies that are listed on the right-hand side, or again, I do think you could use therapeutic dosing the way that you would for a proximal or distal leg DVT, again, for a finite period of time. And when it's safe to see your patient in person, you can discuss next steps. Next slide, please.
Lana, before we move to the next case, there was a very interesting question that came up that I would like to raise at this time. Strike while the iron is hot. Somebody asks, well, how do you know this patient doesn't have a cellulitis? And maybe we should make sure that they don't have a cellulitis before we go straight to anticoagulation or some other diagnosis. You know, perhaps you can just make a comment about the urgency and the approach to anticoagulation when there's going to be a delay in obtaining an ultrasound.
Absolutely. So it is really important to initiate anticoagulation as soon as you suspect a deep vein thrombosis. Sorry about that. So as soon as you do suspect a deep vein thrombosis, it is important to initiate anticoagulation because the potential risk for embolization to a pulmonary embolism is certainly significant that you don't want to miss and not provide anticoagulation. And so as long as it is safe to provide an anticoagulant while you're getting investigations going, that's what we advocate for. And you're absolutely right that there may be a cellulitis or muscular injury, for example, that's contributing to the patient's symptoms. And what I would suggest is if you have the ability to either do a visit with your patient on video chat, or if they can send you pictures and you can see if there's any redness or an ulcer, for example, that might lead you to think that an infection is more likely than a DVT, then you can certainly do another dual-pronged approach where you're providing anticoagulants and perhaps antibiotics until you get those investigations with an ultrasound to rule out deep vein thrombosis.
Thanks very much, Lana. Our next case is about switching from warfarin to a direct-acting oral anticoagulant. And in this case, we've got a 79-year-old patient who has been receiving long-term treatment with warfarin for atrial fibrillation. And you finally reached a point where we're going to move her over because we don't want her attending the labs and exposing to COVID-19. So how would you deal with this and how would you approach this switch and minimize the amount of laboratory testing that's required? Jim, can I turn this one over to you?
Sure. Well, one of the key advantages of the DOACs, or direct oral anticoagulants, has been that they do not require any routine laboratory monitoring, as is the case with warfarin. And I think that advantage has become highlighted in this era and going forward. Patients on warfarin often require INR testing every 2 to 4 weeks. If their INR is very elevated, they may be sent to the emergency department to receive vitamin K. We'll talk about that a little bit later. But I think what we want to do right now with this case is just provide the audience and clinicians with a very easy stepwise way to transition your patient from warfarin to a direct oral anticoagulant with as little as just one single test or visit to the lab. So let's go to the next slide. I think it is important to obtain a baseline INR in that patient before you make the switch. And the reason is that you want to know what their level of anticoagulation with warfarin is, because that will determine how long you wait before you start the direct oral anticoagulant. And as you know, warfarin is a drug that has a very long half-life, so it takes anywhere between 4 to 5 or 6 days for the anticoagulant effect to recede completely, whereas direct oral anticoagulants work almost immediately after intake. So we want the INR, or the anticoagulant effect, to be close to normal or near normal when we initiate DOAC therapy. So if we obtain a baseline INR on our patient, and let's say it's between 2.1 and 3.5, then if we do this on a Monday, then it's pretty safe for us to start that DOAC on day +4 or on the Friday. With our knowledge of the pharmacokinetics of warfarin, we're pretty sure that that level is going to be around 1.5 or less, and that it's safe to start a DOAC on day +4. On the other hand, if the INR is 2 or less, then we can start the DOAC immediately and not have to delay. And on the other, further, if the INR is higher, let's say between 3.5 to 4.5, we add an extra day before starting the DOAC. And then if the INR is at a point where we get a little bit concerned about the effect on coagulation function, then at that point it may be reasonable to recheck the INR on day 4 or day 5 and resume the DOAC when the INR is less than 2. The whole message here is that in most patients, a single blood test, a single INR will suffice. And the second point is that we do not have to do daily or alternate day INR tests to watch that INR level gradually decline before we have confidence in the safety of initiating a DOAC. Next slide. And I want to stress that we're changing patients from warfarin to a DOAC who typically have atrial fibrillation, that's the dominant indication for warfarin therapy, or venous thromboembolism. But as you may know, we do not do this for a patient with a mechanical heart valve, whether aortic or mitral. And there are a number of options that we have in terms of DOACs. On the right-hand side, you see Thrombosis Canada has a dosing tool for patients with atrial fibrillation that will provide you with dosing options and the actual dose for each DOAC according to the patient characteristics. So we have twice daily options with apixaban and dabigatran, and also with rivaroxaban, and this is for patients who are receiving the low-dose regimen in concert with an antiplatelet drug for peripheral arterial disease or chronic coronary artery disease. And we also have a 1 daily option with either edoxaban or rivaroxaban, and a lower dose option for rivaroxaban just for patients with venous thromboembolism. So the key message here is that you're going to transition to the DOAC. There's a tool available that will help you to do so, recognizing there are 4 different DOACs and there are different dose regimens that should be individualized based on patient characteristics that include things like renal function and age. Next slide, please. So I think we're going to transition back to Alan, and we're going to look at situations where patients may have bleeding and what to do there.
Thanks very much, Jim. Our third case is going to be around anticoagulant-related bleeding. So our 60-year-old male patient on long-term warfarin for a mechanical aortic valve, where you want to keep the INR in the range 2.5 to 3.5, a little higher, calls your office because of nosebleeds that he's been having for the last 3 weeks. He's worried about going to the ER in this time of COVID-19. He's not taking aspirin or non-steroidal anti-inflammatories. He describes bleeding intermittently, sometimes from the right, sometimes from the left nostril. It occurs about 3 times a week and lasts 20 to 60 minutes, usually resolving fairly promptly with local pressure. He's had no other visible bleeding or bruising. He's had some lab tests done, interestingly, and his hemoglobin came back at 115, showing a hypochromic microcytic pattern, normal being 125 to 140, and his INR a little high at 7. So what do we recommend here for warfarin dosing and INR monitoring, and what about vitamin K? Sorry, Lana, can I turn this one over to you?
Yes, thank you, Alan. So this is a gentleman where, as Dr. Douketis mentioned, warfarin is our only anticoagulant option due to the aortic valve that he has. It's a mechanical valve, so we cannot use a direct oral anticoagulant. And although his INR is slightly elevated outside the range at 3.7, what's also interesting and concerning is that he has a hemoglobin of 115, suggesting that perhaps there might be some other bleeding happening beyond just the nosebleeds that he's describing more recently. And in the setting of nosebleeds that are happening as frequently as they are, lasting anywhere from half an hour to an hour, I do think this is a patient where, if it's at all possible, to bring them into your office so that you can examine them and potentially do cautery to the nostrils to identify a vessel that's exposed and bleeding. I do think that's an important consideration that we can do to minimize ongoing bleeding. Other things to consider, especially in the drier winter months, is whether or not they're using a saline spray, for example, to keep the mucosa moist. Using a nasal lubricant would offer the same sort of strategy. So if it's at all possible to try these conservative measures to minimize ongoing bleeding, and then bringing your patient in for an assessment and potential cauterization, if you have the ability to do that, that would limit further nosebleeds potentially. In terms of what do you do with the warfarin dosing, so on the right-hand side of the screen, you can see a clinical guide that we have, which gives recommendations for modifying the warfarin dose depending on where the patient is with their most recent INR. And it will give you this recommendation in terms of proportion of dosing increase or decrease of the warfarin, and when to do the next INR test. And so I think that's a nice tool that you can refer to on the website. In this setting, I wouldn't advocate for giving vitamin K because our patient isn't having significant hemoglobin drop with the nosebleeds. And although it is a frequent occurrence of the bleeding, I don't think we need to entirely reverse the anticoagulant effect, because we need to balance the fact that we don't want his valve to thrombose and potentially cause a stroke. And so vitamin K is really reserved for patients that are having moderate to severe bleeding, or for patients where their INR is significantly elevated without bleeding, and that's typically when the INR is measuring above 10, for example. Next slide, please. So what are the things that we can do to reduce a patient's risk when they are on an anticoagulant? And so as Alan mentioned already, our patient is not on any co-administered therapies such as antiplatelet agents or anti-inflammatory medications, which can also increase bruising and bleeding risk. So if your patients are on those medications, you want to review whether or not they're necessary. And if they can be stopped even for a short period of time, that may help to reduce the immediate risk of bruising and bleeding. And as Dr. Douketis mentioned in the last vignette, when can you switch from warfarin to a DOAC? We have that tool on the Thrombosis Canada website. And I do want to reiterate that this patient with a mechanical valve is not the patient that we are going to switch from warfarin to a direct oral anticoagulant. That would only be in patients where they are on warfarin for atrial fibrillation or for venous thromboembolism. When can you use a low dose direct oral anticoagulant? So the low doses are listed there. And again, the tool on the Thrombosis Canada website that helps you determine the dosing strategy is a great opportunity to review this. And if you're using low dose direct oral anticoagulants for atrial fibrillation, it is important to do this according to the product monograph, so that we don't unnecessarily increase somebody's stroke risk, for example. So it is certainly reasonable if somebody is having bleeding complications to temporarily reduce their dose of anticoagulant, but to remember that we need to reevaluate that and increase their dose back to the correct dosing once the bleeding has resolved, so that we don't increase their stroke risk by having them on too low a dose of anticoagulant. Next slide, please. These are the types of bleeding events that we're talking about that really should not be overly concerning. So nosebleeds are certainly concerning to patients, but from a healthcare practitioner perspective, not overly concerning for us. And the measures that I mentioned earlier are certainly strategies that we can try. Bruising is very frequent and very common, especially as patients get older. And again, encourage them just to be mindful of bumping themselves and minimize co-administration of antiplatelets and anti-inflammatories as you can. And so these are examples that I think you don't necessarily need to be too concerned about. Next slide, please.
Right, thanks, Lana. Our next case is about perioperative anticoagulant management, something that, in my experience, has been very much the Wild West out there, and so often it is dumped onto the primary care physician, for example, when the dentist calls and how to manage that. So in this case, we've got a 74-year-old patient with a atrial fibrillation and a CHADS-2 score of 4, taking a DOAC. And he's got a flare of inflammatory osteoarthritis that he tells you about on the phone that's been bothering him for the last 2 weeks. It's been bothering him to the point where he's having difficulty with his activities of daily living. Just walking around the house is causing him a lot of pain. You really don't want to use a non-steroidal anti-inflammatory drug in this individual who's on an anticoagulant, and he's been using Tylenol himself without much improvement. So in the past, you've injected his knee, and he's gotten a good response to it. And on the phone, he's asking if you can inject it again, and you agree to an office visit for injecting intra-articular steroid into this man's left knee. But what about that direct-acting oral anticoagulant that he's on? How should it be managed? Jim, can I turn this one over to you?
Sure, thank you, Alan. And this is, as Alan said, a very germane problem that is very common, especially in a primary care setting. And really, there are two types of patients that we're dealing with. The first type is a patient such as this, who you want to do a procedure in your office, hopefully sooner than later. And then the second situation is a patient that you're caring for who's scheduled to have an elective procedure or surgery. And we know that in many hospitals, some of those situations are starting to be ramped up. So back to this patient, in all cases of managed perioperative, or in this case, peri-procedural management, the anchoring point is to ascertain or estimate a patient's procedure-related bleeding risk. Now, there isn't any standardized way to do this, but the applications through Thrombosis Canada that you see on your right there provides you with a bit of a roadmap to help you stratify patients according to their risk for bleeding, and whether that is high risk in patients having a major surgery, lower moderate risk patients having a less invasive surgery, or a low to minimal risk involving a large number of patients who are having procedures such as a intra-articular injection, in this case of a corticosteroid, or other procedures, whether they are dental, skin biopsies, angiography, cataract surgery. So that guide will help you to stratify your patient. And of course, there will be individual factors. For example, everybody that's having a dental procedure is not the same. Dental cleaning is different from a root canal. It's different from somebody having multiple extractions with poor underlying dentition. The thing to remember, though, in all of these patients who are receiving a direct oral anticoagulant is that there is a simple sort of approach, and this is based on what's called the PAUSE study, which was just recently published about a year ago. And the rule of thumb, if you want to remember anything from this case, is that if a patient is on a DOAC and they're having a low to moderate risk for bleeding procedure, they stop their anticoagulant, their direct anticoagulant, for 1 day. So 1 day off, and then they take nothing the day of the procedure. If they're having a procedure or surgery associated with a high bleeding risk, then we simply add a day, so 2 days off before and nothing on the day of the procedure. The only exception to that rule is patients who are on dabigatran and have impaired renal function. Because this drug is cleared by the kidney predominantly, we add 1 or 2 extra days of interruption. In this particular situation, there may be an argument that you don't have to interrupt anticoagulation at all. The only caveat is that, as we mentioned earlier, DOACs act very quickly. So if I'm going to take my DOAC in the morning, my peak effect is going to be 1 to 3 hours later. So it's probably not a good idea to tell your patient, okay, take your DOAC in the morning and come by to my office later that morning and we'll give you the injection. You may, in this particular instance, want to tell that patient, you know what, either skip your DOAC for this day or take it at supper or at bedtime. So overall, you want to assess the patient based on their risk for bleeding with the surgery, or in this case, the procedure. There is a tool on Thrombosis Canada that provides you a bit of a roadmap.
We lost.
So you want to just wait a bit before giving them the DOAC around the time of the procedure. I think we can go to the next slide in our next case, and we can come back if there are questions regarding peri-procedural management, because there's a lot of potential scenarios that can be involved.
So thank you very much, Jim. Jim perhaps was being very modest and not mentioning that he is the first author of the PAUSE study and probably the world's greatest authority on perioperative management. I don't mean to embarrass you, Jim. Our final case, case number 5, is regarding frequency of INR monitoring. And this is a 57-year-old female with a mechanical mitral valve that's been implanted 6 months ago on warfarin. She's also taking low-dose ASA, which is often recommended in mitral valve disease. She has INR testing done every 2 to 3 weeks, and she's got excellent INR control with her TTR being greater than 70%. She's a little nervous about attending the lab and wants to know, can the frequency of INR testing be safely reduced? Lana, can I turn this one over to you?
Thank you, Alan. Next slide, please. Thank you. So these are slides that are courtesy of Dr. Shiva Kumar, and these were presented in the 2 previous Thrombosis Canada webinars. So I will review them again here, and we can talk about questions after as well. Next slide, please. So what do you do with patients that are on warfarin and they do require INR monitoring? Now the patient in our case is quite stable with greater than 70% time in therapeutic range, which is quite excellent in fact. And many patients are worried about leaving their homes to go and get blood testing done. And so what we do ask is that people consider stretching out the frequency of how often INRs need to be done. So if your patient is going monthly and their INRs have been in the correct range, then it's very reasonable to extend that as long as you are considering what the bleeding risks are and what the thrombotic risks are. And again, that goes back to the reason why your patient is on warfarin. So are they on it for a very recent blood clot in their leg, or are they on it because they have a mechanical valve, for example? Those are things that you need to consider when we are looking at stretching out the frequency of INR monitoring. What we do know from a lot of the studies, such as the PAUSE study that Dr. Douketis led, is that when we interrupt warfarin for short periods of time or direct oral anticoagulants for short periods of time, we know that the risk of stroke in those few days is quite low. And so it might be safe to potentially extend our duration of INR monitoring. Next slide, please. So what can we do for our patients? So if your patient is getting monthly INRs, then it may be very reasonable to stretch that out to every 6 weeks or every 8 weeks. And it's also important to look at where they are getting their INRs drawn and what we can do to facilitate stretching that out. And we'll talk about that in a moment. As I mentioned, you do want to consider what is the bleeding risk and what is the thrombotic risk when considering doing less frequent INR monitoring. And so for patients with atrial fibrillation that have a low CHAD-65 score of perhaps 0, 1 to 2, then it might be reasonable to stretch out your INR monitoring to every 8 weeks. For patients that have DVT or pulmonary embolism that's diagnosed 3 or more months ago, it's very reasonable to consider stretching out the frequency of INR monitoring. And for some patients that have aortic valves that are relatively new within the last 5 years, for example, their thrombotic risk is a lot lower. And so it may be reasonable to increase the duration between INR monitorings. Next slide, please. So when we talk about where your patients are getting their INR testing done, there are obviously many community labs across Canada as well as labs in hospitals. And many of them have done a great job at trying to promote physical distancing. And they've also scheduled times that patients can pre-book so that they are minimizing exposure to other people also visiting these labs. And so if your patient is able to pre-book, then what they do is show up to the lab facility. They can wait in their car until it's time for them to go in, and they go in and get their blood work, and everything is done in a very calm fashion that's pre-specified with everything in terms of precautions in place to minimize risk of exposure. In Quebec, they have community health centers that have also been utilized to expedite this process. And in our hospital lab, for example, we do have the ability for patients to do this as well. So these are options that might be available to your patients where they can pre-book things and make it easier to reduce that risk of exposure. Next slide, please. Other ways that you can potentially reduce frequency or location of INR monitoring, and if your patient is worried about going to a lab facility, some pharmacies do carry point of care machines, which are very similar to glucometers that diabetics use. And there's a picture of it there on the bottom right-hand side. And so pharmacies that have this, your patients may be able to go in and have a finger poke with a test strip that monitors their INR, and it's immediately read. And so you have the INR available immediately. And then your pharmacist may be able to provide dosing recommendations as well, or can at least provide you with the INR reading so that you can then carry on with the dosing recommendations. There are also point of care machines that can be purchased by patients, and they are approximately $400 to $500. So it is an investment that the patient does required to make, and many private drug insurance companies are not covering the cost of these devices, so it would be an out-of-pocket expense to the patient. While there is that initial upfront expense, there's also the cost of the test strips, which are similar to the glucometer test strips. They're very expensive at about, these ones are about $10 per strip. So you don't necessarily want a patient that is monitoring their INRs very frequently using this, because it can be quite costly. But if your patient is monitoring every 6 or 8 weeks, then this is a reasonable investment that they may want to continue to investigate with. Next slide, please. So as we talked about earlier, depending on what your patient is taking anticoagulation for, there may be the option of eliminating use of warfarin and the need for INR monitoring by switching to a direct oral anticoagulant. And this would be appropriate for patients that are on warfarin for DVT or pulmonary embolism, or for atrial fibrillation, for example. With the direct oral anticoagulants, there is no need for routine lab monitoring, which makes it a nice alternative to use. And again, we would not advocate using direct oral anticoagulants in the case vignettes that we've talked about where patients have mechanical valves. There are the options that we talked about in our first case of rivaroxaban or apixaban, because they are direct pill forms and they don't require low molecular weight heparin lead-in for use in DVT or PE treatment. And one of the questions that has already come up is whether or not the different provincial programs are now providing coverage for direct oral anticoagulants. And this is certainly a period of ongoing change. And these 3 provinces listed here, with Nova Scotia, Alberta, and British Columbia, are approving use of direct oral anticoagulants if the prescriptions indicate that COVID-19 is the reason for the prescription. There is certainly interest from other provinces, and whether or not these will be approved in the remaining provinces is to be determined, but we will certainly update our website as we get this information. Next slide, please. Other things to consider are that risk of bleeding with direct oral anticoagulants is certainly low, and so that's another reason you may want to consider switching your patient from warfarin to a DOAC. And then how do you follow up with your patient? So given the times of social distancing and physical distancing, where a lot of clinics are closed and we're doing virtual visits or telephone visits, you can certainly continue to call your patient and ask about bleeding concerns with bruising and bleeding. When you switch to a direct oral anticoagulant and even warfarin, you do want to ask about medication adherence and compliance. Are they taking it? And of course, always asking about new drugs that may be prescribed by a specialist, for example, where you're not yet getting the information from that interaction with the patient, and ensuring that if you're starting a direct oral anticoagulant, you're looking for potential drug-to-drug interactions that you need to consider. And what we talked about earlier in the patient that was on warfarin and having some nosebleeds, indications for holding warfarin and when to administer vitamin K, as we talked about with the information available on the Thrombosis Canada website. If your patient has an INR that's less than 10, very reasonable to hold anticoagulation for a few days. And vitamin K doesn't need to be administered if they're not having any bleeding. Next slide, please. Okay, Alan, I'll turn this back to you.
Thanks very much, Lana. Thanks very much, Jim. On behalf of Thrombosis Canada, I'd like to thank everyone for attending today's program. I'd like to express thanks also to Dr. Douketis and Dr. Castellucci for their excellent presentations and answers to your questions. I also would like to thank our sponsor, Bear Canada, for their unrestricted grant for this program. As I said, if you're interested in reviewing this program again, please watch our site, as it will be posted shortly. Please be sure to complete the evaluation following the program today, and be sure to visit our website regularly and often, as we add new materials all the time and are always updating our clinical guides and tools. So with that, I wish you all a safe afternoon and safety throughout the rest of COVID, and hopefully, as I said at the beginning, that maybe we're starting to see the light at the end of this tunnel. Bye-bye now.